Thank you very much for your kind introduction, and I would like to thank the organizers for inviting me to this excellent ERAS in Cardiac Surgery Symposium. It's a great privilege to be here and a great pleasure to be in San Diego. I just need to go to the next slide. I'm a co-editor-in-chief of an online journal which is supported by an unrestricted educational grant from Medtronic. Enhanced recovery is very much, as you're probably aware, associated with this gentleman, Henrik Kelet, from Denmark. He introduced enhanced recovery. He is a general abdominal surgeon, and this is one of his first landmark papers published in the 90s in the British Journal of Anesthesia. And he introduced the multimodal approach to control post-operative pathophysiology and rehabilitation. Already then, he introduced the three bundles, preoperative, which we have already heard about, intraoperative and postoperative bundle. The preoperative is still very much adopted. It includes preoperative assessment, optimization of organ function, preoperative nutrition in terms of carbohydrate drinks, and preoperative abstinence of perioperative alcohol administrations, and nowadays also nicotine. Intraoperative interventions are more abdominal surgery related with minimally invasive surgery, laparoscopic surgery, but also general measures such as avoidance of unnecessary blood transfusion and reduction of heat loss. Post-operative bundles mainly are very much adaptable to all areas of surgery, including multimodal pain therapy, early mobilization, aggressive treatment of post-operative nausea and vomiting, and stimulation of the gut. So the pillars in the 90s of enhanced recovery were already defined, and these included multimodal interventions towards post-operative optimization, and one can allude to this as an aggregation of marginal gains, which means that one finds and exploits small margins for improvement in every stage. Also, the multidisciplinary team approach is very important, including not only surgeons, anesthetists, intensivists, nurses, and in order to support the communication between these multidisciplinary teams, an ERAS coordinator or ERAS nurse is really important as a sort of communication hub for all of these different multidisciplinary interventions. And in the UK, every general surgical team does employ an ERAS coordinator or nurse in order to monitor, to audit, and to implement the ERAS protocol. And this is the audit is part of the implementation of the ERAS bundles. And the most important question is what Henrik Kelet always said, is to ask, why is the patient still in hospital today, and can the length of stay be reduced, and how? And he actually sent this as an email to me because in our study, which I will come to in the next couple of slides, we were not able to reduce the length of stay, and he said this is really an important question which we need to ask if we do ERAS studies. So we looked at a small number of patients, 53 before the implementation of the ERAS protocol. This is enhanced recovery in cardiac surgery, and 52 patients after. This started about 6 years ago, and the bundles that we implemented included preoperative and postoperative bundles, which were mainly adopted from the general surgical bundles, including preoperative assessment and detailed information for the patients, and carbohydrate drinks not only up to 2 hours before surgery, but also in good amounts the evening before surgery, and multimodal pain therapy. Postoperatively, early mobilization, also aggressive treatment of postoperative nausea and vomiting, and mobilization or drug treatment to mobilize bowel movements. The patient characteristics, because this was a prospective cohort studies, were fairly similar, so there were no differences in patient demographics. There were no differences. I'll rush through these slides, and apologies for that because of the limited time. So there were no differences in the pre-morbid status, including the risk scores, left ventricular function, and other comorbidities. And the surgical characteristics, they were very similar. The results showed that, non-surprisingly, with the ERAS protocol, patients were much less fasted, so they had fluids until about 4 hours before surgery. Before implementation, this was 12 hours. And the intake of solid food also was much improved on the first and on the second post-operative days. Pain scores, interestingly, with the multimodal approach of our protocol, were significantly reduced, and this was despite a shorter duration of intravenous opioid infusions. And one of the weaknesses of this type of study was that it was unblinded and not randomized. So obviously this can be seen as a weakness, especially with outcomes such as pain scores. However, I think one really has to ask whether it's possible to randomize these patients. If you have 2 patients who are next to each other preoperatively and one patient receives all attention receiving carbohydrate drinks, and the other, in the NHS our patients are often next to each other, the other would not be would be randomized to the control group and not receiving any. And so the question is, which is the best approach to study this? And we decided, because of this and because of the potential ethical reasons, to go ahead with a cohort study. Post-operative number of patients with one or more complications were significantly reduced after the introduction of the ERAS protocol. And as I mentioned before, the length of hospital stay was very similar, but it was already quite short, with 6 days. In the pre-enhanced recovery group, usually in the literature is about 7 or 8 days as a median, or other studies, for example, Leipzig Heart Center had 9 days for their fast track group and for their non-fast track group. So they also couldn't show any difference in the length of stay. And one might ask whether it's actually realistic in our very heterogeneous cardiac patients to improve the length of stay, especially with all the comorbidities that our patients have. So as a conclusion, we could demonstrate that ERAS is feasible and has the potential to improve post-operative morbidity after cardiac surgery. Why is enhanced recovery the standard of care for all specialties? In the UK, for the last 8 years, enhanced recovery has been introduced and implemented in most specialties, however, not in cardiac surgery. Cardiac surgery is not yet a part of this movement, and enhanced recovery in general, excluding cardiac surgery, is very well summarized in this review, and I would like to quickly go through the bundles, but before that, just reiterate the advantages. So the enhanced recovery guidelines apply mainly for abdominal surgery, gynecological surgery, also upper abdominal surgery, but also more recently for head and neck surgery, breast reconstruction, thoracic surgery, and one could also list cardiac surgery further down here in the line. The advantages have been demonstrated very clearly: shorter hospital length of stay by 30 to 50%, less postoperative complications by 30 to 50%, reduced readmissions, and reduced costs. The bundles that have been used are now 4. So there's one pre-admission bundle of ERAS interventions, and then one admission, one intra, and one post-operative. And these bundles include, for example, cessation of smoking and alcohol, again, the carbohydrate drinks, and optimization of chronic diseases. And all these bundles have been addressed and approached within ERAS in cardiac surgery. And during this meeting, you will hear more about that. Preoperative bundles of ERAS interventions include the carbohydrate treatment here, prophylaxis against nausea and vomiting, and again, a lot of these are applicable for ERAS in cardiac surgery. How about intraoperative bundles? These are more abdominal specific, for example, epidural anesthesia, nasogastric tubes, so they don't really apply for cardiac surgery. And post-operative bundles are more general, and they are again applicable for cardiac surgery. And these bundles, such as early mobilization, multimodal approach to opioids, sparing pain control, and audit of outcomes have been addressed by ERAS in cardiac surgery. Support of return of gut function there isn't much literature in cardiac surgery about this. However, that's something that could be applied also to minimize postoperative nausea and vomiting. So to me, with all this evidence, enhanced recovery is very similar, and these are my last slides, it's very similar to common sense, and we should all use this common sense. The conclusions are, and I'm coming back to Henrik Kehlet, he published a enhanced recovery what about in the future paper about 3 years ago, but the themes and topics are still applicable, and they are that there's an urgent need for better implementation to fill the gap between knowing and doing. And we always need to ask, why is the patient still in hospital today? What are the benefits, or the benefits of ERAS do include not only shorter length of hospital stay, but also reduced ICU and hospital readmissions. And there is a large importance of multidisciplinary collaborations with ERAS. And the question is there how we best study enhanced recovery, whether we should use randomized controlled trials for our improvement protocols, or more cohort type studies such as step wedge cluster randomized trial. Thank you very much.